Adrian said he doesn't like the word journey, so I'm on a voyage of discovery. So I've got my prop with me, which will be useful for tonight. I wasn't allowed to bring many other garments of clothes, so you'll find out what's in. Yes. So we will dip into this evening. And before I start, so you've had my job titles because the most important thing is I'm a GP. And all of this is about us and patients, and that's the most important point. And the other bit is the relevance of the pink socks is that I'm going to be doing this presentation like this the entire way around, and there will be rewards for people for participation. So the relevance of the pink socks is that we need to change healthcare from the bottom up. This is not a top-down approach, and it will fail. Healthcare is about connection, connecting with people. And as a clinician, the best part of my job is when I connect with the person. This is not a techie project. And if it becomes that, you might as well go home. You have failed. But when you think about the patient, that's when you'll succeed. Cool. And it's a bit about this. It's about connecting, holding people. I hold many of my patients' hands in clinics, and we make a connection. And if the technology gets in the way, we've failed. How many clinicians are in the room? Right. How frustrating is it when you're like doing this, when you can't look at the patient and find the data? So what we need to do is solve that problem. And when you do get pink socks, he's tweeting away, when you do get pink socks, you become very happy. So it's until you start wearing it and being part of this community, this tribe, you don't really know what it feels like. But look at the expression on his face. So, data. We now know, it's been sort of stated that over 1 million catalogues of information have been published every year now. You can buy a USB DNA sequencer from the UK, plug it into a machine, and it spits out in almost near real time the DNA sequence of whatever you throw at it. So what is the most valuable thing in the world? It is the data, and we need to connect it up to get the value we need from it. And this is the problem. I can't even consume and understand all the content I need to know, the guidelines anymore. I need tech systems to be connected to help me. And medicine is transforming. It has to transform from the medicine of what it is today, which is 1 or 2 types of drugs at a population level, might not work. How many patients do I get back saying, oh, the antidepressant didn't work, the blood pressure tablet didn't work? Actually, medicine has to transform to become personalized. Targeted drugs against the DNA that we have. We even hear about microbiome, the bugs that we carry in us affecting us. That's all what? It's data. So we better get real about the importance of connected systems. Buy from a vendor who doesn't connect, you've failed. So part of your role is to make sure whoever you buy from connects to other people. Otherwise, you've failed on this journey. Trory, is it a journey? No. He's tweeting as well. So there's a prize in this or two. Why do I like data so much? So, audience participation. You are now back in World War II, okay? Your job as top mathematicians is to solve this puzzle. Your colleagues in these fighter pilots are going over enemy territory, get shot down, don't come back. That's bad news. You've been tasked with finding a solution to this problem. This is a picture of the planes that go over pristine. And this is the picture of the planes that come back. The circles are the bullet holes. If you do know the answer, don't tell us. It's for those who don't. So your job is to answer this question. How do you reinforce these planes? Who's going first? Do I have to put a pink sock out? Who's going first? Come on. Who's going first? What would you do? Top mathematicians of the country. Where would you reinforce that plane? I've got 10 minutes with a patient, right? Right. Where would you reinforce that plane? Pass it to the gentleman at the back. The wings. Why the wings? Biggest. Okay. Would you reinforce all of the wing? All of the wing? It won't take off. It's too heavy. Oh, more pink sock. What would you reinforce? The part where the what? Why would you do that? There's no bullet holes there. Why would you do that? There's no bullet holes there. But there's no bullet holes there. Who's next?
There's no bullet holes because they're the planes that didn't come back.
Ah, clever man. You can have one as well. You put your hand up. Right. So, those planes didn't come back. And the point of this story is, it's the information that you don't have that's really important, right? That's what your job is, to connect up and share the information that you don't have. The information I've got, I don't need. So as a clinician with 10 minutes, I need other pieces of information, and the Jersey Care record is going to solve that problem. It's got to give me fast access to the information that I don't have. Who's this guy? Oh, I've got some more left. Oh, Hippocrates. Yeah, well, there we go. You've got two now. You can have one of those. Right, so what did Hippocrates do? Do no harm. And that's what the Data Saves Lives agenda is about. So interoperability, or the sharing of information, and that Jersey Care record is all about the information that we don't have. If you are putting in the Jersey Care record, think, are we doing no harm by this piece? That's what it's all about. Who do you think's wearing these socks? Any ideas? Now, you have met these three people today. Any ideas? Who's wearing the sock on the left? No, you're wrong. Same? On the left.
Tweeter.
Yeah. Who? Oh, you guessed, but no, that is Mr. Adrian Byrne, who just presented. And the middle one?
Chris.
Yeah, that's you. Here we go. Right. Here's a story. So the other tip that you need to know to get the Jersey Health record is you need to have a really important story that hits you here. It has to hit you here, because that's the why you're doing this. If you don't have your story, and I guarantee you, you will find many times on this journey incredibly difficult, frustrating. You will want to give up. You'll be frustrated with your colleagues, with the vendors, with the politicians, everybody. If you don't have your why, you'll fail. And this is my why. It's about the story of baby M. What's this? Anyone know what this is? Growth chart, right. And there are dots on it. So we're going to go to a simulation of this. Those dots, I've put black dots on there. Over here is weight. Over here is time. Baby M, when he was born, should grow along that centile. Right? That's normal. And if his weight drops over 2 lines, that means there's something wrong. We should investigate. Now, baby M, by about this time, was starting to vomit. He was happy at home, had no fever, no diarrhea, was having his milk, but was just starting to vomit. And the parents are thinking, oh, maybe something's wrong. But remember, this sits where? At home. A piece of paper. Went to the health visitor, got weighed, keep an eye. Week goes past. Now, if I was an algorithm, what would I say? I'd say, oh, there's a bit of a variance going on here. The change is increasing. I might ask you a few questions. You might put some things down on the data collecting algorithm on an app. Can't do that here. Can't do anything of that. Keeps on vomiting. He's happy. No fever, more data, no diarrhea, still data, all this data at home. Dad takes him to the doctor. He says, something's wrong. I've been with my child for 3 odd weeks now. He's unhappy, he's vomiting, he hasn't got a fever, but something's wrong. Well, why don't you just keep an eye? Now, this doctor with 10 minutes hasn't been living that life for the last 3 weeks, hasn't had all that data around, doesn't know what's been happening, but who does? Comes back to the personalised healthcare record. Who does? The family, the dad, the mum. Come back in a few more days. Doctor goes back, patient goes back with baby M and says, I want a referral. He's still vomiting. If you don't give me that referral, I'm just taking him to the hospital. So the GP gives the referral, and the dad takes baby M all the way up to the hospital, up to the PAU, Paediatric Assessment Unit. A registrar looks at him. Oh, he seems fine. No, you wait. I'm going to feed my baby, and I guarantee he's going to vomit. 1 minute later, vomited. Calls the consultant. The consultant comes. Now, the medics in the room might start to think, well, this sounds like a condition called pyloric stenosis, where the stomach is narrowed and the milk goes out because of the route of least resistance. Because as the baby's getting bigger and bigger, it needs more and more milk, so it's not trickling into the intestines anymore, so it's coming out. The consultants come in, feel for that knot, that muscle that is a textbook thing, can't feel it. Look for the ripples of the stomach contracting, can't see it. But they agree to put baby M on a drip. By the time they make this decision, they have to shave baby M's scalp and put a line through a vein in the scalp. Quite distressing for both baby M and parents. And they take him to have a scan the next morning, and he has the biggest pyloric stenosis they have ever seen. The operation is done, and look at the recovery. Now, the reason this is my why is because he is my boy. He's my baby M. His name is Mowgli. He's now 8. Annoying git at times, but he's now 8. And I firmly believe the reason he got better care was because I'm a doctor. And that's not fair. So that is the reason that I'm driven to do this, and I firmly believe in the personal health record future. We need to unlock that data, digitize it, and make the patients and the citizens part of it. Didn't Adrian beautifully explain liver disease? Where did you get your medical degree, Adrian? Because you were brilliant at it. And why can't our patients do that? So any healthcare provider who goes, oh, the patients don't understand, don't go back to them. They do understand. Healthcare is not that difficult at that level. So the challenge we're facing is the patient comes in, I look at my computer, I try to fill in the gaps, and that's what the real world is like, and that's what you're trying to solve. Because actually, you need to free up my time to do this. And those bits of information are really important. An extra piece of data can change liver to a name. And my job is all about those extra pieces of data making something else appear. It changes treatment plans. And unfortunately, let's accept the reality out there. This is the journey that patients are taking on. They're going to different sectors. If you're joined up, I don't believe you, because I haven't met one health economy that is. And they've got all those records in silos. That's the challenge for the patients. That's what you're here to solve, and find your why. It's really going to be important when the going gets tough, and I promise you it will do. So, I coined the Robin Hood principle of information sharing, which is what all of you are going to be, Robin Hoods. You're going to help take the information rich and share with the information poor to fill in those gaps, because data does save lives. And pyloric stenosis, the Twitter feed on this is going to be hilarious, isn't it? God, I'm going to be out of a job tomorrow, aren't I? Don't record that. Because pyloric stenosis actually does kill. It does kill. And my son was saved. I'm going to take this off if you don't mind in a minute. So, a possible Robin Hood Jersey care record might look like this. I have a little bit of confirmation earlier that the model isn't too far out of sync. The Hampshire healthcare model is like this. So you're going to get data feeds in from different sectors into a care record that gets accessed. There'll be privacy and security around that. And the cool thing is you'll take some of this with some privacy to the patients and the public into an analytics database, and you'll do that pop health bit. And you're going to get my medical record from UHS, aren't you? You are definitely going to buy that because that's a brilliant application. And the patients are going to start looking at their record and contributing. And why does it make a difference? Because Actually, I find stuff on there. When I had a patient fax from a district nurse saying, I think you might need to go and discuss a do not resuscitate form with this elderly frail lady, I looked at my own care record. And actually what it said was the partner of the patient was not keen for the patient to know about her diagnosis. So I was thinking, this is a bit funny. The district nurse wants me to go in. The partner doesn't know. Something's a bit funny. And I haven't actually got any clinic letters in my clinical system. So what did I do? I went and looked at the Jersey care record. And what did I find in the Jersey care record that you can find? Oh, she's quite aware of her diagnosis. She understands there's no role for surgery. And by the way, this is palliative. So that previous consultation, actually, the partner was struggling. It completely changed the context of what I did. You know those little elements, those different bits of data that came out? It completely changed. And that happens to me day in, day out. So your job to deliver that, you're going to help me and you're going to help your citizens to have better care. We did some analytics, just to give you some more data. So we looked at what happens to the number of investigations that are carried out. These are preliminary kind of data. They weren't validated in a scientific way. So these are correlation studies. What happens when you go into the Hampshire care record, the Jersey care record, and you find data? And what happens when you don't find data? On those patients that you find data, you do less tests. Why? Because you found data that you didn't have in your own system. It makes sense. You do less radiology tests, less blood tests. It's less waste of time for the patient. What about the travels that they go on that's unnecessary? What about the length of stay? Now, that's big bucks. So we looked at a period of 8 months, 2 hospital sites, about 18,000 spells, and when data was viewed at, when the clinicians went into the shared care record, the average length of stay for those patients was about 10.5 days. But when they went into the shared record to find stuff and they didn't find anything, the average length of stay went up. Statistically significant results. It's quite hard to prove the cause and effect entirely, but that number scaled up is in the millions of pounds when you look at bed days. And that's for 8 months. You've already got your business case. But don't think it's all about the data going in. There are some enablers. So I want you to think about single sign-on. I'm in my clinical system, and from there I go into the Jersey care record, or I go into another system. Do you want to? Who has to use another username and password? I mean, that's just ridiculous. You will not get any usage if you go for a system where you have another username and password. Just don't do it. From the start, you have to have in-context single sign-on. So a hospital site, this was Adrian's hospital, we put in single sign-on. The red line is the number of access to records over time, and the number of clinicians is the blue line accessing the shared care record. Or there's a pink sock up for grab if you identify when single sign-on went on. Okay, here we go. Right, it's pretty obvious, isn't it? And look at that. So the problem with this is, what the hell were the clinicians doing over here when they were making decisions? You cannot go that way anymore. And probably the last and most important part of this story is that we've just talked about data moving, accessing data. We've talked about enablers where you can go into another system. But what we're really moving to a world is where actually we're separating the data layer from the application layer, okay? So everyone in the room, the techies will understand this, the non-techies, I consider myself a non-techie, need to start understanding this, need to start challenging the vendors, need to start challenging the program managers and the IT department, because the data must become separate from the application layer. And Adrian talked about this. And the way these two start to talk is through these standards, open standards, where the data can move to any application. And then you start paying. It's not pound, is it? I didn't know what the sign was, sorry. You start paying for customer service. You start paying for great user interfaces. You start buying software not because the data's in there, So when a vendor says, oh, I've got access to the data, don't go with them, because you're actually committing suicide, right? You need to force them to open up so they can move the data around. And this is this open system that we're talking about. And so what we did in the UK about a year and a half ago was we created this community called Interopen, Interoperability and Open Standards, and we said this is a community for anybody, in particular vendors, who believe in openness, transparency, and using national open standards and to create them. And actually, you will use them to move data around as these standards develop. It's called Interopen. Adrian, Andy, myself are on the board. And the point of this is we've recognized patients move around the system, but when you boil it down, the priority information is pretty much the same, right? For clinicians. You can create standards in a technology called FHIR, which I understand there'll be more learning about this in coming months, where you can use building blocks of technology to transmit medication, problems, allergies. And what we're doing in the UK is trying to create a national standard for allergies, problems, so that the vendors all use those and will open up their interfaces. And these are all the members of Interopen now. So this is a social movement. This is, are your vendors in there? If they are, they've signed up to openness, transparency. You can go out and go, we asked you to put open interfaces, and you're a member of this group, well, why aren't you doing it? You could write to the board and ask them to be removed. I imagine a big company with shareholders might not like that. This is also about social pressure. And just lastly, have I got time? So standards are quite hard to understand in a technical world. So I want you to think about Volvo and cars. How many of you drove here and used a seat belt? That's a standard. That, just like every car has that. That's like the technology standards that we're talking about. You just plug it in and you're safe. So I just want to show you a quick video to understand the parallels that will exist on this journey. Oh, sorry. I've got to turn it up. Give me a sec. It's too loud, let me know.
The three-point car. An invention that has saved more than 1 million lives is being celebrated this month. The three-point car seatbelt is seeing its 50th anniversary. Here's more on this story.
In an age of high-tech gadgets and interactivity, it's easy to take the innovation of the past for granted. The three-point seatbelt is one such invention. Introduced half a century ago, it was arguably the most crucial advance in car safety history. Inventor Niels Bohlin's creation was initially greeted with scorn. But the Volvo safety engineer was backed by his employers, propelling him into the annals of history. Last week, Volvo marked the 50-year anniversary of the first delivery of a car fitted with the belt. Current truck safety director Thomas Broberg paid tribute at a Gothenburg ceremony.
Initially, there were actually other solutions, two-point belts, and there were a lot of controversy, customers not really believing in it. And Niels Bohlin, when they invented it, they had a struggle actually to convince both customers as well as governments around the world about the benefit of the technology.
Volvo introduced the seatbelt on all cars in 1963. They then set out to persuade their competitors of its merits. A groundbreaking report was commissioned. All injuries suffered in accidents involving Volvo cars in a one-year period were recorded. The results were unambiguous. The seatbelt reduced or prevented injury in more than half the cases. From that point, there was no going back.
Today you can actually find a three-point safety belt in every car, even though it took some time to actually convince the world that this was a great invention. It has shown a significant benefit to mankind in the sense that it's reckoned that it saved more than 1 million lives during this past 50 years that it has been in production, so to speak.
In most
So, it was a difficult journey for them, but it was the right thing. It saved lives. They had to convince governments. They had to talk to their competitors. Open standards is the same journey. If you can show in Jersey the importance of open standards, you will have helped the rest of the world and not just Jersey. So that's got to be built into the way you do things. And lastly, this area is difficult to understand. I've been struggling to understand it. So last year, I think actually this March this year, 2 other doctors, Kian Hughes and Wai Kyung Wong. Kian Hughes works for Google DeepMind, and Wai Kyung Wong is a hospital hematologist, and myself set up the Interop Summit, which is all about data saves lives. And if you go to the Interop Summit website, www.interopsummit.com, you will find videos of what interoperability is about. It's like a 101. They're all freely available. This is onboarding material for all your IT department. It's been quoted by many software vendors. Go online, access it, learn about it, share it to people who are interested. So when you next look at a growth chart, hopefully you'll see what I see now. You'll see the ability to use open standards to unlock the data silos, to put the data to work, that data saves lives, and you won't forget to see the patient. Thank you very much.
So we've got some time for questions for Amir, who I'm hoping we can get back to appear in Canto maybe for December. Have you got any questions for Amir before we move to the panel? I'm sure quite a few.
Don't worry if you don't. You're all tired and had a long day. We can go to the panel. I'm happy to.
Anyone? No? Oh, here we go. Philip.
I'm a politician, so I'll always ask questions. Sorry. A brilliant presentation. Thank you very much. Really inspiring. A boring question, but links straight in. There are governments in the UK and across Europe and here in Jersey are putting new data protection laws in place, and that's going to that is obviously putting data in the hands of citizens. Is there any problem that you see with the way the UK is approaching data protection that is going to stop you unlocking this this dream, this reality of what's there? And is there anything in Jersey that we should watch out for, because we can do things differently, but yet we need to comply with the EU legislation?
So I think the ultimate answer in, what's the population size?
105,000.
Right. It won't cost you much to get consent from patients now, starting this process and getting a growing mechanism of consent. That will solve all your problems. Get them online, identity verify them, get the consent done. You'll have solved half. Well, let's think about it. Direct care, right? Will they share my records? To what context? Give them a set of questions. Co-produce the level of consent that they want to share. Co-produce it with people. They're your citizens. They're public. What about sharing it for analytics uses and research? Put it on there. There's probably about 7 or 8 types of categories. Probably 90% of them will go, do what you want, I trust you because of these mechanisms you've got in place.
You've not been to Jersey before, right?
Well, I bet you, but I bet you, my patients come in and they're absolutely shocked that I don't have access to their records. Right? Just think of yourself. When you were to go in to see a clinician, wouldn't you feel like, well, of course I want you to access. So this is about comms, engagement. Put videos on, explain how it works. The benefit you will derive from doing that engagement now, you will reap.
I think that is something we should be able to do. I mean, I've always said
Easily.
Jersey would be great. You can have the town hall debates here because we've got
Easily.
12 of the bloody thing. You know, you can. It's small enough that you can engage and you can explain and you can educate.
That's the solution. And you can count on, I was the IG Information Governance Chair for Hampshire Health Record, where we had analytics questions coming to us. People wanted to pay for it. You can count that not far from your shores, you've got experts in us who can come and help you. We've done it. Hampshire Health Record's been around for 10 years.
Can we do that? Do we think?
You need to do that.
Suggestion in the evening already.
Co-produce with your patients. It will not be as difficult as you think, and a lot easier now than the difficulty you'll face later.
Patients need to understand why this stuff matters. Politicians pontificate and say that they know best, and regulators are interesting.
So when you get the public involved and educated, I find normally politicians and regulators start to respond for the nudge factor of an educated public. The problem is most people don't want to educate the public on this stuff.
You're going back to the panto.
It's a good It's a good point about education, because I remember, I think it was ITV when we launched the digital health strategy at the beginning of the year. They ran this ridiculous piece where they, as they quite often do, is they stopped people on the high street, they didn't give them the information, and they were like, how scared are you of having it? And there's so many people said, oh, well, I'll opt out of that. I'll opt out. And when I get asked by the media, I say, well, okay, people say that, but if you then say to people, okay, so you get admitted to A&E in the middle of the night, you're unconscious, do you want them to access your data? Yes, of course they do. Okay.
It's context dependent. That's the biases that people bring in. It's comms and marketing, isn't it?
Yeah.
There's a lot of bias.
Yeah. Okay. I think we definitely have to take note of that point. Any other questions for everyone to come? Okay. Shall we? Thank you again.
Thank you. Thank you.